aí, pessoal, vamos começar mais um videocast da Saesp. Então, vou falar que o tema é PBM e a gente está aqui. Um prazer, a gente ter três pessoas, melhor dizendo, dois brasileiros, a doutora Liana e Vicente, como você já bem conhece, o professor Kai, direto de Frankfurt, para falar com a gente sobre PBM, uma sumidade no assunto. A ideia é que aqui seja informativo, leve e
Solto.
altamente amigável. Então,
Científico.
E científico, antes de tudo. Posso começar?
Claro.
Bem, my first question actually is a informal conversation. I'd like to know from Professor Kai, how was the PBM in the beginning in German? What's your challenges there? What's the main idea? And how the main difficulties that you handle in that time to start? Because sometimes here in Brazil, the people think, I will never put PBM here, we'll never get PBM here. Maybe PBM is just for big centers in Brazil. We know that is not true, but I'd like to hear from you.
Yeah. Number one, I'm so happy to be in Brazil. So that is the most
We know it's true.
Okay.
Here, also Brazilian guy.
The second thing is I have implemented PBM 17 years ago in Frankfurt. And the evidence was already there. So I talked to our surgeons and I told them, look here, this is the data. And I said, okay, we like it. So I talked to each of the bosses of each department. And I said, we like it. And okay, we will support you. And we set up a PBM walking-in clinic, an anemia clinic. And I said, yeah, wonderful. And then after 2 weeks, no patient was there.
Wow.
So I said, oh no, they all betrayed me. So I talked to the surgeons again. I said, no, we like it and everything. And then I realized it did not work because we were working in parallel, but not together. So I sent my PBM nurse, my anemia nurse, to the surgeon's daily clinic. And she became friend with all the other nurses. And suddenly all the patients came. So you have to work on a personal level. And this is the trick.
Well, it's about connection, right?
Indeed.
Yeah. What kind of data have you shown? I mean, what kind of data we had to have to show that what is important?
Yes. I can tell you one thing. You will break the heart of a surgeon with a wound infection. The surgical wound infection is one of the worst things what happens to surgeon.
Makes sense.
And we know that patients with preoperative anemia and or transfusion have a multiplied risk of wound infection. So same procedure, everything the same surgeon, the risk is far higher. So this is where you catch them.
Yeah, you catch me now because I had no idea about it. We all think about anemia and to show what is important, how important it is to up the hemoglobin levels and so on, or costs. But I had never had this response, like wound infection.
Because this is a direct measure of the surgery, not a wound infection 2 weeks later, yeah? But a few days after surgery is the worst thing what can happen. And you can measure it and you can compare.
It's easy.
That's easy.
Okay.
Então,
I like to think about hemodulation normovolemic hemodulation.
Normovolemic modulation. What do you? Yeah.
Hemodilution. We used to do hemodilution in cardiac surgery, like in my institution. We are not doing it anymore because we don't need it anymore. So because we have set up the cardiopulmonary bypass machines with a far smaller volume, everything is smaller. So we don't have this big volume shift anymore. And the cardiac surgical patients, they really benefit from PBM even 2-3 days prior surgery. And from us, they get IV iron, erythropoietin, and the vitamins, everything in one shot. And we hardly do hemodilution anymore. We used to do, we were good in it, but we don't need it anymore.
Yes.
Great. And Kai, I watched your lecture a couple minutes ago, and saw you to talk about the app. I'd like to talk a little bit about this app, how changed, what do you expect? And I know that probably in the next 3 months we have this app in Portuguese. Tell me about it, please.
Yes, yeah. So the project's name is the Donor and Transfusion Registry, and it is related to blood. Anything related to blood. So it does not mean solely blood transfusion, or platelet transfusion, or plasma transfusion. Also, if you administer coagulation factors like fibrinogen, or you give oral iron or IV iron, or you give hormones like EPO, everything related to blood. And the idea behind is to collect data, long-term outcome. We do not know anything about long-term outcome of for example, transfusion. There was some years ago a little study. They did something really interesting. They followed up people who were transfused and they were suffering from dementia. And they could go back to the donors. And the donors were at the time healthy, but some of them became, they received dementia, and their blood, which has been given to patients, they also were suffering from dementia. So there's some protein. So we don't know anything about long-term effects. So what we are going to do in this register is a very simple thing. We are collecting the patient's data, but we are working together with the patients. The patients will receive from us after 3 months and then after 1 year for 30 years, every year, an email and a text message with a special link. They press on the link, and it takes less than 5 minutes, and they're being asked simple questions. How's your exercise? Are you frail? Do you have any new disease? Do you have anything very similar? This for 30 years. So what we are trying to find out is now, because every year millions of people are being transfused and everything. What we would like to find out, is there any signal? It could be a good signal. It could be a not good signal. We don't know.
Yes.
You're very open. I transfuse, and I've saved so many lives. I'm not against transfusion. The only thing I want is the right patient with the right indication, the right product with the right dose.
Yeah. Perfect.
And now coming back to your point, yes, the app, the whole software is now we have the ethical approval, we have the data protection approval, it's been registered in the clinical trials, everything is done, and now it's a translation in important languages, and one of them is Portuguese.
Wow.
There you are.
Perfect.
I have a question about preoperative preparation, or how to prepare a patient to go through a big surgery. And I would like to know about the preoperative clinic, the anemia clinic. How do you manage? What kind? How long? How many times from the? How much time? Sorry, from the day you see
And
and then the surgery. Let's say
very
it's
good
like
question. It's a very, very good question. And at the beginning, like 17 years ago, I had employed special nurses which are trained as a PBM nurse. And they did the whole business. But then I realized PBM is a doctor's business as well. So now every of my doctors training in anesthesiology and intensive care, they have to work also in the PBM clinic. And we combine it with our pre-medication clinic. So if you do the pre-medication for the patient for surgery, they also have to learn how to use sonography, they have to do a lung function test, and they also have to do the iron testing, everything to find out if someone is anemic and what kind of anemia it is. So So we have implanted it there. So to come back to your question, ideally, and that works quite well when the patient has been seen by the surgeon a week or 2 weeks before. We're seeing the patient as well. We take a blood sample, and an hour later we know the results. And then if they need, we can do already the IV iron infusion whatsoever. Sometimes we see the patient only the day before or even on the day. We still do the testing, and if they are anemic, we still treat them on the day of surgery. Because the data are very clear, because we have seen that they recover fast after surgery than other patients. So it does not matter when. The most important thing is you do it. But ideally, 10 to 14 days prior. That would be ideal. That would be paradise for the patients in a positive way.
I have a question. What is the management of Jehovah's Witness in your country?
In my country, what?
About the Jehovah's Witness,
Oh, yeah,
patient with
Yes.
the eye transfusion.
Yes. I'm the how could I say? I'm one of the main people for the Jehovah's Witness in Europe, and the biggest conclave is in New York, and the second biggest is near Frankfurt. And yes, it's the second biggest in the world. It's near Frankfurt.
Tower, right?
And yeah, and they have a whole city.
Yeah.
It's unbelievable. So I organized that. All my colleagues, all the directors signed a paper with the Jehovah's Witness that we respect a policy of not transfusing them, but we all signed only for adults. We are not signing for kids.
Yeah.
And I won't sign for kids. I won't do this. And they call us weeks before surgery, and we tell them what to do, and they're the best prepared. They're the best prepared, the well-educated. And also what we do is when we have a transplantation or whatever, or big cardiac case, the best surgeon is operating and the best anesthesiologist. So we put a team together of the best, and that works.
The best
Really?
physicians, the best professionals. Yeah. Everything is correct.
Yes. So it's a bias at the end of it. It's bias because you get the best people on board, but these are the most critical patients because they are not accepting blood. And last year in September, I won my first court case at the European Court for Human Rights. You can watch it on television. On YouTube is a 2.5-hour video of the court case. So 30 judges of the European Union will all come together. What was the story? There was a lady from Spain. She had uterus bleeding, and she was bleeding, and she had a hemoglobin of 6. And she was fine. She was not sick, but she was bleeding. So the doctors in the hospital said, well, we sent you to the University Hospital in Madrid, and they do an embolization of the uterus. And she said, yes, that's what we're going to do. And then something happened which was unbelievable, because she was in ambulance being transported to the University Hospital, and doctors at the University Hospital in Madrid called the judges saying she cannot judge about her own life. We need to have carte blanche, meaning, and the judge has given them permission to do whatever they want with her. She arrived in the hospital. They put her under anesthesia without her consent, took her uterus out without consent, and have transfused her. The bad thing was she was also a Jehovah's Witness. So I was the medical referee for the court, and Spain is guilty. Spain lost the case, the whole country. And this is now a binding verdict from the court, for European Court of Human Rights. It's binding for all European countries. So that is a new thing. So I'm very proud of this.
Yeah. Wow. Good story. But we are almost, the time is finished, I think. I have one question more. If you have to give a tip for us, Brazilian people, that you are starting PBM here in Brazil, and you have to give us one tip how to start, how to build this long program in the important program. Of course, us as anesthesiologists, né, in Brazil, we try to change the culture all day, every day. We build here a lot of workshops in the education, wherever. But you are 17 years, 20, almost 20 years ahead of us. So give it just one tip about your experience for us.
To be fellows, it's quite simple. You need someone who's motivated. That's the most important thing. That is the most important thing. The second thing is you need partners. So you need to look for partners, and ideally, it's a project of surgery and anesthesiology and intensive care.
Yes.
So you need your partners, you need to build a little group, and maybe laboratory medicine as well, clinical chemistry. So you build a little team, and you're looking out for the low-hanging fruits. Do not start, oh, we want to be champions. No, start with the small little things, which can easily be measured, monitored, and has an impact. And this is the way I would start.
Start idea.
No matter how.
Specific, temporal.
And you have to have then with your little group, and you need to have a name like Brazilian PBM Warriors or whatever. You need to have a little, you have to have a little item, or angels, your PBM angels. You need to have a name. You need to have regular meetings once a month, and you have to have a goal. And I tell you, and I promise you, you get the donor and transfusion registry. You will get it, and you get it for free. And that could be something as a start you can use.
Yeah. Great tips. So, any question more? It was a great pleasure to have you here with us, the videocast, all Congress. It's for us, it's an honor to share this table with you, Kai. Thank you very much.
Pleasure.
Obrigado. Obrigada, é o alemão mais brasileiro que eu conheço. Ele e o Klaus são os alemão mais brasileiro que eu conheço. Pessoal, espero que vocês tenham aproveitado. Aproveitem o congresso, aproveitem as aulas. Foi um prazer ter vocês aqui com a gente. Até o próximo videocast.
Hello, everybody from Brazil. My name is Kai Zagarowski. I'm from Frankfurt, and I'm practicing patient blood management for the past 20 years. And I'm going to invite you to be part of the big family PBM, but also I invite you to be with my colleagues here from Brazil with the Congress, and also to watch our little conversation, how to start, what is the benefit, what can you do good for your patients at the end of the day, good for your hospital, for the healthcare, for everybody. And I'm always saying I would like to have my family also being treated according to PBM if they have to undergo any intervention in the hospital. So thank you very much for listening. Thank you very much for being here. I will come back to Brazil, definitely.
Uhul!